past era, limited drugs, no targeted drugs, no combination drugs, cumulative dose of each drug is high, lifespan and metastatic diseases was often too short, cancer killed the patient. In the present era, early diagnosis, therapy, targeted drugs, combination of 2 or 3 drugs, survival from cancer possible, it prolongs life and leads to cardiotoxicity of the cancer therapy that kills the patient now. These are all two types of toxicity. Number one is irreversible damage, usually due to anthracycline and its derivatives. Pathophysiology is necrosis and apoptosis. Leads to progressive cardiovascular disease and heart failure. And the second group is typical reversible dysfunction, leads to cellular dysfunction, mitochondrial and protein dysfunction. After cessation of treatment or completion of treatment, the normalization of the cardiac function usually occurs. The manifestation of cancer therapy related cardiac dysfunctions are previously known as cardiac dysfunction. Now it is termed as cardiovascular dysfunction because vascular diseases are becoming more common. Number one is heart failure, myocarditis, vascular toxicity, both arterial and venous manifestations are there, hypertension, arrhythmias and QT prolongation are some of the manifestations of chemotherapy. These are all some of the drugs that lead to accelerated atherosclerosis and coronary artery disease, hypertension producing drugs, arrhythmia leading drugs, and heart failure producing drugs, and vascular manifestations may occur due to these drugs. Some drugs can produce pericardial inflammation and pericardial effusion and so on and so forth. The basic recommended investigations are ECG should be done in all patients starting with chemotherapy. Basic baseline measurement of natriuretic peptides and cardiac troponin should be done in all the cases prior to starting treatment. Echocardiography is recommended as the first line modality of treatment of cardiac function in patients with cancer. Baseline comprehensive transthoracic echocardiography is recommended in all patients with cancer at high risk and very high risk before starting cancer treatment. And this is more important. The oncology protocol, echo protocol, is little bit different from conventional echo protocol. First, you should, in the report, you should write timing of the echocardiography with respect to infusion. Number of days before or after the chemotherapy, you should mention in the echocardiographic report. Vital statistics like blood pressure and heart rate should be incorporated. 3D EF is preferred than the 2D. If 2D is available, Simpson's method is the drug choice. GLS, when you incorporate GLS in your echocardiographic report, which echocardiographic machine, which brand you are using, which software and software version should also be mentioned in each time of the echocardiographic report. In the absence of GLS, measurements of MAPC and tissue Doppler imaging can be done. RV, TAPC, S prime wave and FAC can be done. These are all some of the left ventricular factors that should be incorporated in the echo protocol, and right ventricular things that should be RV dimension, S prime, TAPC, FAC, free wall strain, RA area, peak tricuspid regurgitation, IVC dimension and respiratory variations, valvular and pericardium should be concentrated. And these are all the 2022 guideline definition of cardiotherapy related cardiovascular toxicity definition. The top one is symptomatic CTRD. We are not bothered right now. And asymptomatic CTRD is the current point of interest. Severe when the ejection fraction is less than 40. Moderate when the reduction of ejection fraction is equal to more than 10% to the baseline to the point of 40 to 49. And a new relative decline in GLS more than 15% from the baseline or new rise in cardiac biomarkers. Mild is ejection fraction equal to more than 50%. relative decline in GLS more than 50% from the baseline, new rise in cardiac biomarkers. In what way it is superior when compared to ejection fraction? That is our botheration now. Looking at the various societies and various bodies that do study in cardiotoxicity, European Society, American Society, all those things, there is a varying cutoff for ejection fraction, 50, 53, 55, 55, 50, like that. But in the lowermost column, if you see, all the bodies concur with one point, relative reduction of GLS more than 15% from the baseline. That is a constant factor. And coming to the studies, conventional echocardiographic parameters cannot identify the early drop in ejection fraction. There is no significant difference, including ejection fraction. And this is the ejection fraction, no significant change from baseline. 1 month after anthracycline, 3 months after anthracycline, no significant change in the ejection fraction. In one study, there is isovolumic relaxation time slightly prolonged, but other studies did not reveal the same fact. And tissue Doppler, no tissue Doppler derived parameter could identify in the early hour. That is, first month or third month, no significant change. But when you look at the global longitudinal strain or global circumferential strain or strain rate, they begin to fall even as early as 1 month, and they gradually fall further. And this is the only parameter which can identify as early as possible. And coming to the example, this top column denotes that is a basal echocardiographic study. Before starting anthracycline, ejection fraction was 78. The second method ejection fraction is 64. That is automatic edge detection technique. 64 is the ejection fraction. Exactly 3 weeks after anthracycline therapy, the same ejection fraction, 78% was there, and no significant reduction in the other ejection fraction also. But look at the global longitudinal strain, the right column. Before starting treatment, that is global longitudinal strain was 21 minus 21.8. 3 weeks after starting anthracycline therapy, it has fallen to 17.6. That means there is absolute drop of 4.2%. Relative drop, that means how to calculate relative drop. From 21.8, it has dropped 4.2. For 100%, what would be the drop? That in this case, this is 19.2%. So that what is the importance of the relative drop? When the relative drop of GLS as compared to the baseline less than 40 means there is no evidence of subclinical LV dysfunction, this patient can proceed with the next dose of chemotherapy. And when the relative drop is more than 15, there is evidence of subclinical LV dysfunction. So in the previous era, we were stopping this chemo or restarting it at a lower dose. But now we can continue chemotherapy and along with the cardioprotective agents. That is the importance of global longitudinal strain relative drop. And a recent study, that is SACUR trial in 2021, baseline echocardiography in a cancer patient was done and potentially cardiotoxic chemotherapy was started. Echo surveillance, it was divided into two groups. One is echo surveillance group during therapy. Another is GLS surveillance group during therapy. And cardioprotective agents were started simultaneously. After the end of 1 year follow-up, they have calculated the ejection fraction, which was worse in 65% when the echocardiographic surveillance group was followed up. 65% were landed up in poor LV function when compared to the baseline. When compared to the baseline, the abnormal GLS group identified the fall in ejection fraction early, and the cardioprotective drug was successful, and 61% of the patients reached normal ejection fraction, whereas 65% were leading to the abnormal ejection fraction and recurrent cardiac failure and poor prognosis. Coming to one study, strain-oriented strategy for guiding cardioprotection initiation in breast cancer patients. And in this study, the message was From the baseline, the GLS was 19.9, the ejection fraction was 60. They have identified based on subclinical dysfunction based on GLS. GLS has reduced to 14.2 after 1 month, and the ejection fraction reduced to 56%. That means the ejection fraction was reduced to 6%, which is not under the guideline. That is, it should be more than or equal to 10% fall should be there. And in this case, ejection fraction was not significant, whereas subclinical LV dysfunction by GLS has significantly reduced more than 28%. But after continuing the treatment with cardioprotective agents, the treatment with the trastuzumab was completed, and again with the cardioprotective drugs, GLS improved to 18.9 and the ejection fraction also improved. And these are all the cardioprotective agents: ACE inhibitor, ARBS and beta blockers, dexamethasone, liposomal anthracycline. When the patient receive anthracycline, statin should be given to all the patients. Thank you very much.